Good evening. My name is Tim Gibbs with Delaware Health Force. We are a program of the Delaware Academy of Medicine and Public Health Association, and we welcome you on this significantly cooler evening than the last time we met. So, early fall, Delaware Mini Medical School 2025. You can follow us on social media, and in a couple of minutes here, I will drop the YouTube stream link into the chat. So if you have any problems with the Zoom client, you can watch it there. You can always go to YouTube/Delamed302. We do this in partnership with the Sussex County Health Coalition, and I'll introduce you to Christy in just a minute. There's a special program we wanted to let you know about, and again, I'll put this link in the chat as well. There's a Pathway to Physician program that's being done by the Delaware Institute for Medical Education and Research, the Department of Health and Social Services, and the Delaware Health Sciences Alliance. There's a link here where you can find out more and register. There are going to be 3 sessions, 1 in each county, although they're Zoom connections. So if, for instance, you were in Sussex County and you wanted to hear from some Sussex County physicians, that's the one that you should go to, but they're all going to have more or less the same content. Housekeeping tips. Remember, this is a Zoom webinar, not a Zoom meeting. So we don't see you. You all don't see each other. You see the panelists and myself when I'm on camera. Please don't use the raise hand, only use the Q&A feature to ask any questions. And remember not to ask any questions of a personal nature for HIPAA privacy concerns. We'll attempt to address all questions. Christy and I will handle like the back office questions about attendance and whatnot, but we will try to leave all the clinical questions to our 2 excellent presenters for today. And remember, you do need to stay through the entire presentation to be counted as present, but once the Q&A starts, you can leave, although you've missed the good stuff then. At this point, I'd like to introduce my colleague, Christy Handley, and she'll tell you a little about Sussex County Health Coalition and then introduce you to this evening's speakers. Christy?
Great. Thank you, Tim. I appreciate that. Sussex County Health Coalition is a coalition down in Sussex County that engages communities in collaborative focused efforts to assist our children, youth, and families in the Sussex County area, although we do work with a lot of families in the Kent County area as well. And what we do is we raise awareness of health issues. We bring them to the forefront. We want to make sure that we are hearing from the communities themselves so we can promote some of that healthy community work and do make sure that you guys are getting all of the community resources that you need. And this time of the year is our Delaware Goes Purple campaign. So I will drop a link into the Sussex County Health Coalition website so you can take the pledge to help us go purple for substance use. And we have an event on November 14th at the Calvary Church in Dover, and all of that information is on our webpage as well. So I invite everyone to please join us to knock out substance use disorder. So I'm going to now introduce both of our speakers. Tonight, we are thrilled to have Latorre-Tegtmeier and Robin Maracle from Bay Health talking to us about palliative care. I'm going to turn it over to Robin and to Terry.
All righty, and just a reminder, once again, we don't use raised hand. Please put your questions into the Q&A. I'm going to stop share and turn it over to our presenters. Robin, over to you.
Thank you, Christy. Thank you, Tim. Let me get our screen up. See if I can do this. It's not my strong point.
You did it.
Okay. Good evening, everybody. I'm Robin.
And I'm Terry.
Okay. We didn't figure out which one of us was going to talk first, so bear with us. I'm Robin Maracle. I have been with Bay Health for going on 21 years this year. We gave you a little collage, just a little snippet of who we are. From a personal standpoint, this is just a little bit about us. I do love group and Guardians of the Galaxy. Being outside anytime I can, it definitely helps balance the work-life thing. And both Terry and I are Harry Potter avid fans.
Yes, we are. And I am Terry. I'm a nurse practitioner. Personally, I am married, as Robin is.
Oh, yeah.
I have 3 kids, as Robin does.
Minor details.
Just helping out a little there. And I love to read. So my favorite princess is Belle. And as you can see, I'm a Lego addict. I'll own that. And I love to go on the beach, and that is my happy place. That's where I get refilled. I refill my cup. Professionally, I've been in nursing for 17 years. It's a second career for myself. I was a bookseller originally. Went to nursing school when my youngest was 2, and went through all the levels of education from registered nurse and associate's degree all the way to my doctorate that I completed in 2022. So
You left out a minor detail.
What?
So Terry actually was the one who started the palliative care program here at Bay Health back in 2015. She doesn't take enough credit for the things that she's done.
Thanks, buddy.
So tell them how we ended up with the palliative care program.
So palliative care program started in 2015. It was started because CAPC, which is our one of our governing bodies, Center for Advancing Palliative Care, did a survey, and Delaware got the grade of a D because we did not have access to palliative care within the state. So the hospitals were tasked with increasing the availability of palliative care, which is how we started the program back in 2015. Like Robin said, I did start it. I was by myself. I was covering 2 campuses, and then slowly but surely we added to our team. We're up to 4 APCs, and we have a physician starting with us in the middle of November. So we're super excited about that. We're looking for a social worker. We're trying to squeeze that into the budget. But yeah, that's our palliative journey here at Bay Health. We are super engaged in our community. We cover both inpatient campuses, and we have an outpatient clinic in Dover. And then as we get more clinicians that we can add on, we can hopefully get an office down in Sussex. Yeah. Good.
And nursing is my primary career. Came a little bit later in life. Once I figured out what I was going to do with myself, not like you guys who actually know what you want to do right now at such a young age.
I love that.
But, which is phenomenal. However, I started out as an aide, ended up as an LPN, started out in a med-surg unit. All of my nursing career is primarily in the hospital. But where I started was primarily an oncology unit, where I was for 10 years, where we took care of cancer patients. And a lot of what I heard from our patients was, I didn't know it was going to be like this. Or I saw a lot of suffering, and they really didn't have good pain management, which it meant they spent a lot of time in the hospital with us. Mm-hmm. There weren't good conversations about what kind of care they wanted, what to expect, prognosis. And so then I moved on to critical care for a few years, where on the flip side, I saw the families, because the patients couldn't talk to us at that point in critical care. But I heard the families saying, I wish I knew what they wanted. And so as I went back for my master's degree, my passion was driven towards advanced care planning. I wanted to help patients and families to have these conversations earlier in their disease processes so that we could have a better end of life trajectory as their diseases progressed. Where Terry met me in the ICU when she was starting the palliative care program. So once there was another position with palliative care, I was quick to jump on it once I had my master's degree and my clinical nurse specialist certification. So I've been with palliative care now since 2020. I started in the midst of the pandemic with COVID. I figured if I could survive jumping into palliative care during the COVID pandemic, we could pretty much survive anything. But I have learned so much more about palliative care since I've actually gotten into it as well.
And we keep saying the word palliative care, so let's just jump into figuring out what this specialty is and how it helps support the rest of the medical team.
Sorry. Told you, computer's not my strong point. We'll get you there.
Go ahead.
Okay.
Next.
So what is palliative care? Palliative care is a specialized medical treatment or a medical specialty for any patient who's living with a serious or a chronic illness. Our goal is really to help focus on quality of life by providing symptom relief that is coming from the disease, Goals of care. It is interdisciplinary between doctors, nurses, social workers, spiritual support, really looking at the patients and the families as a whole.
So truly, I mean, the beauty of palliative care and why it's something that I hold near and dear to my heart is that we have the time to spend with our patients and their families that the other treatment team doesn't have. So when you go to a primary care appointment for something that's going on, chronic management of disease, you have 15 minutes, and that half the time is spent with your medical assistant getting your vitals and documenting any updated history. And then the other 5 minutes to 10 minutes is spent with your doctor. It's very, very hard to have a true goals of care conversation when you are limited in time. So that's where we can take the time to sit down, talk, make sure you understand what's going on medically, and then make sure our treatment plan as a team follows your goals. So I love this word jumble that's to the right, because when you put in palliative care, a lot of people think palliative care is just end of life care, and it is not. It is appropriate at any time during the lifespan, with or without curative treatment.
And it's appropriate despite whatever the prognosis is.
Mm-hmm.
It doesn't have to be that you're terminally ill.
Mm-hmm.
It is you have a serious or chronic illness. Serious illness, the way I describe it to some patients, is you're just in the hospital with a very complex illness. You know, there's
Mm-hmm.
multiple moving pieces, which our role in that
You
is.
seem to be having a problem. Can anyone else, Christy, can you come onto audio?
Yep, I'm here.
Can you hear me?
I can hear you.
Okay.
Awesome, and I can hear you, Christy. Tim, were there a lot of people that were having a hard time hearing?
No, it might have just been on my end. Go on ahead.
Okay. But anyway, so it's not based on prognosis of the disease. It is any stage of an illness. And if you look at this word jumble, I hope you pick up all the words, because these are words that we say to patients and families every single day. Mm-hmm. Things about healing, hope,
clarity, understanding, questions,
treatment, medicine. So talking about what are we doing, even while we're continuing to try to treat our patients from a curative standpoint. There's a little bit of a history of palliative care. I am not going to read this to you guys, but I am sure you can all browse through it. I think the important piece to take away is that palliative care does stem from the concept of hospice. Mm-hmm. Hospice has been around for a long time, back since the 60s. But palliative care didn't really start to take notice until the 80s. So like the early 80s. And then coming into the 90s, the World Health Organization really defined palliative care for us. And then other organizations started looking into it and decided to take into account, can we improve the symptom management of these patients while we are continuing curative treatment? And are the outcomes better? I mean, there's been a lot of research about the impact of palliative care on patients during the course of an illness. And if we can keep them feeling better, statistically, they do better for longer. So in the 90s, it really progressed. In 99, Harvard Medical School actually opened its palliative care academic base. And then in the 2000s, it just blew up, to be honest. 2000s, if you see the number up there, over 157% increase in hospital-based palliative care programs, which aligns with the timeline close anyway. It was 2015 when Terry started, but that's when they were really looking at hospital systems to see it, or even states or statewide, is palliative care available for the patients in this community? And that's where we were able to get the basis for starting the program here, because there wasn't a lot of palliative care in Delaware.
And truly the reason that palliative care was being emphasized was because we were looking for a way to provide better quality care for our patients and getting better outcomes, so that they were showing improvement or outcomes based on what their goals were and what's important to them. And then all in the while reducing the cost of healthcare, because we know that healthcare costs are skyrocketing astronomically. So we were part of that triad where we were focusing on making sure that the goals of the patient were being met, that we were having better outcomes, and that the healthcare costs were, being spent where we needed them to be spent. At that point, in the early 2000s, the majority of Medicare dollars were being spent on someone during their last year of life. Mm-hmm. And that was mostly because nobody was having that conversation to say, hey, what would your loved one want? And giving them the option to not pursue aggressive interventions if they didn't want them. And that was never the case. Always, whenever you're offered an opportunity for treatment, depending on who the specialty is that's talking to you, is going to give you treatment options, but nobody was ever saying, hey, you always have the option to focus on symptom management and comfort and quality of life versus pursuing aggressive treatment. So that's kind of where palliative care came in. We gave everybody all of the options so that they can make the best decision for themselves.
Mm-hmm. So if you look at 2020, now we're at 83% of the U.S. hospitals with 50 or more beds actually have a palliative care team. It's huge. And it's growing even beyond that. So home-based palliative care programs. And I think the best part is the residents, the medical residents actually starting to rotate through palliative care programs. Mm-hmm. So coming from an acute care standpoint, being a nurse in a hospital for many years, I think that was a lot of my frustration, was that obviously that's how I ended up here. But none of the patients were having these conversations with their physicians prior to getting so sick we had no point of return. And what I've learned from our resident physicians is there's still a gap in the education for physicians about palliative medicine, crucial conversations, hard conversations, but we are seeing an uptick in the rotation of physician residents rotating through palliative care teams as part of their education. And we get great feedback. So I'm hopeful, and we're seeing the benefits of it. We see these residents as they grow through their residency. The conversations that they're having with the patients are beautiful.
So much better.
So hopefully the care that's coming to our patients is definitely improving with time. So who makes up a palliative care team? In concept, it varies from place to place, but it should be interdisciplinary. So doctors, APCs, which advanced practice clinicians can either be physician's assistants or advanced practice nurses. Nurses, like plain old RNs, can function as navigators for palliative care teams. Social workers really are a key component. And when you think about a social worker, we're not the typical social worker that you meet that's just going to give you resources for something. They're not just handing you brochures, connecting you to resources. Social workers in palliative care are typically a special group of people who have a background in bereavement support, difficult conversations, holding family meetings. Some of them can even help with the advanced care planning conversations, in addition to the providing the support, because as our patients' illnesses change, they are going to need more help in home. And so then they can give them those resources to help connect them with additional caregivers for home. Pastoral care is huge from a spiritual support as we look at our patients as a whole. And volunteers. We haven't been lucky enough to get volunteers on our team yet, but it is definitely something we are looking at. In the community, some volunteers go out to the homes, or they do the grocery shopping for other ones. Some of them just go and visit with the patients who are homebound and don't have other people, or can take them out for walks. Like volunteers play a huge role in some palliative care programs. I'm going to let Terry talk. This is her favorite picture.
So this is, I do enjoy this, and it takes a little bit, so be mindful. Along, and I'm pointing, even though you can't see me pointing, along the left-hand side, right? That is the progression of life, right? The bottom is your timeline. So the left is prevention and integrative health. So this is the young ones that are eating healthy, that are working out, that are being mindful, getting all their screenings, right? And then as we get older, we start getting diagnosed with some chronic life-limiting illnesses. And when I say chronic illness, I'm talking about things that we have that are managed with medications, but we never quite get rid of them, right? High blood pressure, high blood sugars, diabetes, heart failure, COPD, right? So as our life progresses, at that point of diagnosis is when palliative care is the most effective. Even though it's not used often, we start establishing that relationship, right? I can't tell you how many times that we've had patients that have heart failure, and when I ask them, tell me in your own words what heart failure is. Well, my heart is fine. I see my cardiologist every 3 months. That is not normal to see a cardiologist every 3 months. And your heart is good because that cardiologist is closely monitoring and making sure that your numbers stay within parameters and so on. But they don't understand that it's a progressive chronic disease, right? So what we like to do is we like to provide education. We provide resources of information. We provide support group information, because as you're going through this illness that you're going to be living with, you're going to need that support of those people that have that same experience and might be able to give you some tips and tricks as you go further. Because that's one of those diseases that when you follow best practice, it's very hard. You're on a lot of medications. The medications make you thirsty. You're on a fluid restriction. So there's a lot of complexity, right? And it becomes harder and harder as you continue to age and as the disease continues to progress, which is that curvy line in the blue, right? You're getting older, there's more disease, and there's more palliative care, and maybe less curative because you've gone through all the treatment options. Your disease has continued to outpace what treatments are available, right? So we're working on symptom management. We're giving you tips on how to keep that fluid off of your legs. We're helping you work through the shortness of breath that develops because fluid builds up around the lungs. These are all the things that we help manage in the outpatient setting, all with the goal of preventing hospitalizations, because as your disease progresses, hospitalizations increase.
And maintaining a quality they're happy with. So when you hear
Yes.
Terry talk about not being able to drink fluids, being on a fluid restriction, changing your diets, I'm sure if you all think about what things you enjoy, probably 90% of it is food and drink. I'm just saying,
Maybe.
food and drink bring us all a lot of joy. And that's just
Yes.
one piece of it. But those lifestyle changes
Mhm.
impact people's quality of life. So
Mhm.
when we meet them down here early in the disease process, and we talk about what brings you joy,
Mhm.
what kind of things do you still enjoy that you enjoy doing that it's important for our medical treatment to help you continue to do. Those are the goals of care that we talk about with people.
Yeah.
Because as we work with their specialists to try to help minimize those symptoms, we're looking at, are you still able to do those things? Are
Mhm.
you still able to go out of your house?
Mhm.
Do we need to take rest breaks? Do we need to maybe get a rollator so that you can take it with you and walk and have a sit when you're starting to wear out?
Mhm.
You know, how do we help people
Mhm.
manage their chronic illness but also maintain that quality of life?
Yeah.
Is where we are in this whole middle section that's kind of wavy.
Yep.
Sorry,
Absolutely. No, that's perfect. That's perfect. I love that. And the other thing we talk about earlier rather than later is what do you want when your disease progresses to the point where you can't, if you're not able to eat by mouth, if your heart stops naturally. We like to talk about those things earlier so that you are alert, oriented, and able to make that decision for yourself and know what quality of life is for you, right? And what to expect if you have to go through those things. And we create that bond and that relationship so that there is a trust. So when you do have issues, you know who to call and when to call. Okay. We work in conjunction with the treatment team. So we make sure that we know what the treatment recommendations are. We explain those recommendations, and then we allow that person to make the decision for themselves, whether they want to follow best practice or whether they want a modified treatment plan based on what their goals are and what's important to them. Right. So like Robin said, if it's important to you to have a certain number of beverages during the day and your cardiologist is saying, no, you can only have 3 cups of water a day. We're going to talk about that. We're going to discuss what happens, the risks, benefits, if you follow best practice versus if you don't. And then you're an adult, you make the best decision for yourself.
We also talk about tips and tricks. Like how do you balance it? Can we freeze that fluid? Can we take it in ice chips?
Mm-hmm.
You know, it's It's not rocket science. Some of it is just practical, but it's things that a lot of people don't think about. Like we can try to give them little bits of the things that they enjoy,
Yep.
that make it more tolerable for them to continue with restorative treatment.
And a lot of times, as clinicians, we assume that people know these things, right? I had a patient one time, and I said, I didn't even sit down when I walked in. I walked in to see if she was in the hospital. I said, "Hey, so tell me what's going on." And she spewed off everything. She knew metastasis. She knew stage 4 cancer. She was saying all of those things. And I said, "Okay, so tell me what that means in your own words." And she said, "I honestly don't know what metastasis means." At that point, I got a chair. I was like, this is going to be a longer conversation than we thought. And I did have the time to sit down and talk her through that along with her loved ones, because we never want to have these crucial conversations with the patient by themselves. Mm-hmm. But as for this grid, then there's that little blue vertical part that says 12 months. That's when someone's life expectancy is about a year. Then we start talking about what to expect, right? We readdress those goals. We readdress code status, and we help them transition to hospice when there are no more treatment options available, and we focus strictly on symptom management and comfort. And then at the end, once the patient dies, it doesn't stop there. Then the bereavement support starts for the family. So it really is a full lifespan opportunity, for providing care.
Okay, so we did this maybe a little backwards. What is a chronic illness or a serious illness? Chronic illness, we've talked a little bit about it. Chronic illness is anything we may acquire that is not necessarily curable. It's going to progress in time, but it's treatable. So with any chronic illness, we're not going to fix it. But our goal is to optimize it, to maintain it, to keep it from progressing faster. So I'll give you an example. One is COPD. This is a lung disease that typically comes from exposure to different irritants, primarily cigarette smoking. But it can also come from like people who have worked with drywall for many years, people who've worked with asbestos for many years, people who've been around secondhand smoke. They can acquire COPD, where it starts to damage the lungs. And then over time, anytime they're exposed to any irritants, whether it's pollen, humidity, strong fumes, it can cause what we call an exacerbation, where things flare up, their lungs get tight, they have trouble moving air in their lungs, they come in the hospital, and we can treat it with steroids, antibiotics, breathing treatments. It takes time, but typically we can get them back to their normal. However, each time they have those exacerbations, or each time they're really sick and they're down in the bed for several days, they get more deconditioned, we see a little bit of progression with that disease. Meaning, if they were not requiring oxygen and they were still out and about and doing things, but then they had like a week or two hospital admission for a COPD exacerbation, they might be going home on oxygen this time. That's the progression. Now we might need 2 liters of oxygen. They might not be able to walk the 3 miles that they were walking before. It might be that they're walking once around the block now, needing a little rest period. This is the progression. They follow with a lung doctor, or they should, who can help manage them. Like routine medications for COPD are inhalers that they use. That some are steroidal inhalers to try to keep the inflammation down. But basically what I'm getting at is this is something that is going to progress over time.
This is the blue wave.
Yes, this is the blue wave, exactly. And all those little waves are those exacerbations as they are doing okay, and then they get sick, and then they're doing okay, but we never get back down to where we were, okay? Parkinson's is very similar. This is a neuromuscular disease where people can develop tremors over time. Dementia affects our memory, multiple sclerosis, kidney disease, all of these things. We can't cure them. but we can treat them. And so these patients follow very closely with their specialist. So whether it's a lung doctor, a neurologist who focuses on the brain, a nephrologist who focuses on the kidneys, these patients follow with them, and they follow closely, like Terry was talking about with the heart failure patients. So they're getting medications, they're checking their labs, they're making dietary changes in stopping smoking, all to try to prevent that progression of the disease. Okay,
Or slow it down.
Yeah. That is what a chronic illness is. Serious illness can be cancer. I mean, stage 1 cancer, very curable. We might be able to get rid of it, very likely actually. But it's still very complex, and it still can come with a lot of symptoms that impact somebody's quality of life. So if they have a tumor that's pushing on a set of nerves, whether it's in the ribs, the spine, that's very painful. Now, with treatment of the cancer, that tumor should shrink. The pain will improve. But what happens when you guys hurt? Do you want to eat? No.
Do you want to move?
No.
No.
Can you sleep? No. And so if people can't eat, don't want to move, can't sleep, do we feel good when we can't do those things? And the answer is no. Our bodies are going to fail. And so if we can help manage those symptoms of that cancer while they're getting treatment, help them feel better while they're getting their treatment, the likelihood of those outcomes are going to be better for those patients. There's a ton of research. I would say probably the bulk of our outpatients are cancer patients for that reason, because the research shows, and we see it in our patient populations, our oncology team here has seen it too, that the outcomes of our patients with cancer, when their pain, their sleep, their appetite, all are better managed, those patients live longer and have better outcomes.
And better quality.
Yeah, they're a lot happier. Serious infection could, just like we talked about this one a little bit earlier, this is where somebody just gets a really bad infection. They might, typically those patients have these underlying chronic illnesses, and then they get a really bad infection, and then it starts impacting all their organs, and they're in the hospital. And they could have been one of these chronic illness patients who have still been walking around the block. They've been maintaining well because they follow with their doctors every 3 months. But what happens is when you get sometimes a really bad infection or some serious illness or injury, strokes, anything like that, that can knock them down where they're not able to eat and drink like normal, they're not mobile, our scales tip. And that's where we come in the hospital setting to really listen, number one, to patients and families, to what their understanding is of what's going on medically. And then a lot of education, a lot of making sure they really understand what we're trying to treat, and being there for support, focusing a lot on those goals of care, meaning what are you hoping to see with all this treatment? Nobody sits here in this hospital and lets us come stick you for labs multiple times a day, having nursing come in and turn you, move you, things that are painful, uncomfortable, being away from family. Nobody goes through all of that just because. Every individual is hoping to see something. And that something is your goal. What are you hoping to see with all of this medical treatment? And our job is really to make sure that if realistically we're not going to achieve what their goal is, we need to talk about that openly. We need to tell them, I understand this is your goal, but realistically, this is more likely what we're going to see. And if you're okay with that, we're going to continue to treat. We may not be able to get you back to where you were. This is what we're hoping to see. This is our goal. I'm worried I'm going to knock my coffee over.
No, I'm worried we're going to run out of time.
Okay. But those are those serious illnesses. So now I'll let you talk.
Okay. So I'm from New York, so I'm going to talk a little faster. We kind of touched on this in what we were talking about before in terms of who benefits from palliative care. So not only do our patients benefit through symptom management of chronic disease and illness, but our families and caregivers benefit through the time that we take with explaining what's going on medically, making sure they have a good understanding, making sure they have the resources. It is hard to be a caregiver of someone who's chronically ill at home. So we make sure we have those difficult conversations in a safe, secure setting, because we want to make sure that we're the ones that they're looking at for bringing up the subject of code status. We're not the loved ones. We want to make sure that they know that we're the ones who are asking. We're the ones who want to make sure that their goals are being met, right? And then caregivers and family can be there to support. We're there for the healthcare workers, right? Nurses and doctors don't have a lot of time. They have a large patient census. They have to go all over the hospital, our clinicians. So we're there to take the time to speak to the patients, and we're there to support them as well. We touch base on all our colleagues to make sure that they're okay, because working in healthcare is really hard, and we understand that. And we, again, have the time to not only talk to our patients, but to talk to our colleagues.
And I think we alleviate some of that moral distress, because a lot of
Correct.
times some of the nurses, the doctors, they see these chronically ill patients, and from a medical standpoint, they know where this disease is ultimately going to land. And I think they flounder. Sometimes they feel things are futile. But if we can hone in on that goal, we can share with them the patient's rationale, the family's rationale for the decision makings, what we're working to. It really does help with their moral distress.
Absolutely. Absolutely.
Yeah, Chef, go ahead.
No, you're and again, we're a benefit for the health organization, because we're able to have those crucial conversations. We're able to find out and hone down those goals. And a lot of times people don't want to be on ventilators for a prolonged period of time. They don't want a tracheostomy and a feeding tube because they can't breathe on their own, or they can't eat on their own. And we're able to define what those goals are, illustrate exactly risks and benefits of treatment versus no treatment, and transition them to a better place.
And we look at end of life care spent in like critical care setting with more invasive, more expensive treatments from a healthcare organization. I hate to bring up the business end of healthcare, but it is a business at the same time. And so we look at how much money is spent on critical care at end of life for patients, and it's exorbitant. I will say, what we see in those patients that we've had time to build a relationship with, had time to have these conversations in bite-sized pieces, those patients aren't spending the remainder of their time in the ICU. They may still come in the hospital, but a lot of times they've set those limitations. They know that's not where they want to be. So from a healthcare standpoint, it helps for the cost. It helps to minimize the utilization of our ICU beds so that we can open it up to other people who may have better chances of better outcomes.
Yep.
Okay.
Next.
Did we talk about services down here? All right.
Yeah,
Segue. The second square, the one thing we haven't talked about a whole lot. We've mentioned code status. So code status is like what people want.
I think it's on the next page.
I know. Code status is what people want. Code status applies in the hospital. What do you want if your heart stops or your breathing can't be maintained without a ventilator? That is the biggest thing about code status. Advanced care planning plays a part in that. So that's my segue to our advanced care planning page.
Okay.
Like that was good.
That was good. So advanced care planning is a conversation that you're going to have with your loved ones and telling them what your wishes are if you can't speak for yourself. That's the only time an advanced care directive goes into effect.
And there's a difference between advanced care planning and an advanced directive. Advanced care planning is truly the conversations. It should occur in multiple conversations over time between patients, their physicians, their family. It's little bits at a time. What's up here?
And I want you to think about advanced care planning like an umbrella, right? Every prong is a different part of the conversation. So one is a conversation. One is an actual completed directive on paper. One is a completed directive electronically. One might be a DMOST if your life expectancy is 1 year or less, approximately. So it's all different parts of that.
Yes, perfect. What we have up here are different versions of advanced directives. So in the middle, we have the 5 wishes. Nationally, this is used in 48 of the 50 states. It's written more for a lay person. What an advanced directive is going to tell us from a medical standpoint is, number one, Who is your medical power of attorney? It means if a person can't talk to us and make their own decisions,
Mm-hmm.
who would they want to make medical decisions on their behalf for them?
Mm-hmm. And just a little tip, it does not have to be your spouse or your eldest child. It's whoever you know is going to advocate for your wishes.
And do what you want.
And right.
Yes, that is number one. Second tip, depending what state you live in, there is a law in every state that tells medical professionals, if someone doesn't have it in writing, who we follow the surrogacy law. Mm-hmm. So like in the state of Delaware, it goes to spouse, then
or
children.
Partner.
Oh yeah, now partner.
Mm-hmm.
That just changed like today. So if it's not in writing, healthcare organizations are required to follow the law of the surrogacy. So it's important for anybody over the age of 18 to really have these documents in place. You may say, I'm healthy. And you're correct. I'm healthy. But I could go out and be in a car accident, be in a coma. Our lives can change in the blink of an eye. Mm-hmm. And if we're not able to talk for ourselves, then we want to have the person that knows us best and knows what our wishes would be to be the one speaking for us. And that's what these documents then give that person guidance. So once you fill out the medical power of attorney, you fill out a little further what you would want in certain situations. It is not, I wish I could have had more pages. But it's not a blanket statement. It's not like saying just pull the plug.
Right.
But in these documents, it's going to ask if you're in a terminal condition, and then it defines it. More than one physician says that whether we continue all life prolonging treatment, you're still going to progress to death. That's a terminal condition. Mm-hmm. Would you still want things to prolong your life? Would you want CPR, ventilator, surgeries, dialysis, all of these things? Yes.
And Robin said earlier that the recommendation is 18 or older. And that's because these documents are not one and done documents. These are documents that need to grow and change as you grow and change, right? So in the beginning, yes, full, resuscitation if God forbid my heart stops, or if I have a massive heart attack, or if I'm in an accident. But for an 18-year-old recovering from full resuscitation is very different than from a 95-year-old recovering from full resuscitation. So as you progress with your disease processes and age, your wishes are going to change. And I did want to indicate there is a directive for children. So there are children that are born or develop serious illness, and there is a very child-focused directive to hear what their wishes and goals are.
Which is that one. It's more geared toward kids.
Yep.
But the other ones are like, if you're in a coma, not expected to wake up, what would you want?
Kidneys
if you have
fail?
a severe brain injury?
Kidneys fail. Do you want dialysis?
It depends.
That's in there.
Oh, what? On which one?
In the 5 wishes.
It's a blanket statement. But yes.
Basically, it looks at a lot of different things.
Yes. And it looks at the condition that you're in. Would you still want your life prolonged, depending what your quality is going to be? Mm-hmm. The 5 wishes is actually nice because it actually gives the patient the opportunity. Is there any other condition you would not want your life prolonged in?
Correct.
And it gives a lot of free range for them to write in whatever they would want.
Correct.
The My Directives you see in the bottom right-hand corner is actually an online advance directive, which the state of Delaware is trying to gear towards aligning all the healthcare systems onto My Directives, because we are a small state and people travel between all of our healthcare systems, and it would be very nice to be able to just access people's documents. The DEMOS, the Delaware Medical Order for Scope of Treatment, there is a post form they're in all the states now. These documents are a little different than the advance directive. Okay. So the advance directive tells the power of attorney and gives the power of attorney guidance as to what decisions that person would want made. However, from a healthcare, medical standpoint, we can't just follow this document. We have to talk to that power of attorney about making any decisions. Okay. So if someone has an advanced directive, something happens at home, their heart stops, someone calls 911, the power of attorney is like, here's my advanced directive. They don't want any of this. Unfortunately, those EMS providers have to follow their protocols, and they're going to treat first, do everything, bring them to the emergency room, and then we can make decisions to stop things. However, the POLST DMOST forms are different if you look close, because it's going to be signed by the patient and by a physician, advanced practice nurse, or a physician assistant. And that makes this document an actual order that those EMS can follow. So that's why, like Terry said, this is for those patients that we suspect something may happen within the next year. Those patients that are kind of fragile, they're high risk for sudden events, and they're very firm in what they do or don't want done to them. This form can be completed with any member of their care team, and it gets put on the refrigerator in the home, shared with their medical team, and legally any healthcare provider is required to follow this if the patient themselves cannot speak to us. If the patient can talk, they can always change their wishes. She's rushing me. Go ahead.
So where do we provide palliative care? Oh, I forgot the care part. In hospitals. And here at Bay Health, we cover both of our inpatient campuses, hospitals in Kent and Sussex County, at nursing homes or in the person's home, and also in outpatient clinics and cancer centers. So, for instance, we do see our patients in our Dover clinic, but we also see them in the cancer center of both Sussex and Kent to reduce fatigue.
Yeah, and each state, each
Appointment fatigue.
healthcare system branches it a little bit different. A lot of healthcare systems have their palliative care embedded in their oncology department. There are some that actually have a strictly non-cancer palliative program, and their cancer palliative program separate. So each state, each organization is a little bit different, but these are some of the options.
Right.
Okay.
Patient story.
I love a patient story.
It's so good.
Patient stories really highlight what we do.
They really do, because they give a great example of all the different steps through the disease process where we were able to assist and intervene and help alleviate suffering. Go.
So, okay, I'm going to share this one. And sorry, I tear up a little bit because I remember each patient with each story. This gentleman was a 62-year-old gentleman who had a history of hepatocellular cancer.
Can you tell us about him first?
You want me to?
Yeah.
Okay. Well, I met him way down when. All right. So he was a lovely gentleman, little high strung, and he would completely agree with me saying that. But he was a butcher by trade. He had worked in different butcher shops over the years. He loved to cook. He was a motorcycle rider. Loved to be out in the yard cutting logs. Oh my gosh, he was always out in the killed me because he was always out in the yard cutting stuff up, cutting trees down, working in the yard, working on cars. But he had a history of hepatocellular carcinoma, which is a cancer that typically starts in the liver. Sometimes it can come from if someone has been exposed to like hepatitis C over the years, which he had been. He had actually been treated for the hepatitis C, but then developed the hepatocellular cancer. SP, by the way, means status post. Sorry, my abbreviation slipped into the slideshow. He had a liver transplant when he was much younger. I met him when he was 62 years old. He had had the liver transplant. He had made out beautifully. He was in remission from his cancer. It hadn't spread anywhere else. When he was probably, I think he was around 60, when he started to have pain in his bones, found out that the cancer had spread. It had reoccurred. It came back and had spread to some of his bones. And he had been going up to the University of Pennsylvania and seeing oncology up there, was receiving chemotherapy, and seeing actually their palliative care team up at U of Penn. But it was getting harder for him to make the trip from our area here in Delaware, an hour and a half up to Penn. And in order for them to be able to prescribe for him his pain regimen, they needed to see him in person. So they referred him to our palliative care program as an outpatient. When I met this guy, he was starting to really decline. He was so frustrated the day I met him. He was sitting in the chair with his arms crossed across him, head hung low, Just, what are you going to do for me? And don't take away my pain medication. So when he had first had the cancer, they had put him on a very heavy pain regimen. He actually admitted to me that he had become dependent on them and really had a hard time coming off the pain medication. Didn't want to go back on pain medication initially, but then did. And he had been on this super low dose for a long time, for about 2 years, was doing okay with it. And he was so fearful of going through withdrawal if he couldn't have his pain medication, and fearful of if the pain was uncontrolled. He wasn't sleeping, he wasn't eating, and he really was just failing treatment overall because he wasn't eating, he wasn't sleeping.
Ready?
Yes. Click. Okay. So we built a relationship. I should have put that first. The one thing I did with him was really sit down and reassured him that we are here for whatever his needs are going to be. We can certainly continue your pain regimen for now if it's working for you, but my concern was it was not working for him. Mm-hmm. And then what we talked about, what can we do other than just pain medication? So we got him referred over to the radiation oncology to see. He had a lot of radiation in the past. Fun fact, you can only get so much radiation to your body, and in the same spot. Mm-hmm. He thought he had been maxed out. We sent him over. They were actually able to radiate for him in the area at that point in time. And so with the radiation and his current pain regimen, he was doing much better. We talked about, because he couldn't eat a lot of food, he and I did a lot of education about how can we add calories and fats to foods in small amounts. So how do we get the most bang for your buck to try to keep you up and moving? We did end up adjusting his pain medications over a couple of months. Through our visits, we started talking about advanced directives and demos. He was not married, but had been with a significant other for many years. She was definitely the person he wanted making decisions, had children, sisters, but he did not want them making decisions. So that was a high priority for us, because I needed to educate him that without these documents, otherwise it would be his family making decisions, and he did not want that. So we got those documents done. Then we had a lot of ongoing support with medical decision making. I got to know his phone number by heart because he would call me, he would talk to the different doctors, and he would call and he'd say, this is what they're telling me. Can you break it down for me? Because they use such big terms. And he was a smart man, but some of the terminology and not feeling well, it was just too much for him to process. Or his significant other wasn't at the appointment and he was trying to explain it to her, and then he would call me and have her on the phone so I could kind of break it down to both of them. So as we talked through and got his symptoms better managed, his appetite improved. One day I go to see him in the cancer center, and he had ridden his motorcycle in. However, then probably not long after that was when he called me, because he had hurt his shoulder, he thought, by chopping wood outside in the yard. When we did imaging, we found that he had further progression of his disease. It had also spread to his shoulders. Working with his cancer doctor, we looked at what other treatment options. If he's still having progression of disease, can we try anything else? He was very hesitant. So we had a lot of conversations because he had such a bad response to some of the other treatments with side effects. He agreed to try one. We trialed it. The side effects really, we implemented different medications, tried to stimulate his appetite, but nothing was working. We decreased the dose of the cancer treatment. But what we ultimately figured out was the amount of treatment we were giving him was just enough to cause the side effects, but it wasn't going to fix his cancer. And so after myself and the oncologist sat down and talked with him, he decided it was time for him to stop treatment. We had open conversation. That means his cancer is going to progress. He did not want to go to hospice right away. And a lot of times people, when they stop their cancer treatment, that's the next step. Here, let's get you a referral to hospice. He was not ready for it. He was still doing things. He was like, I want you to continue to manage my pain. And so we came up with a plan and talked with him and his significant other that we could certainly continue to manage his pain until we had exhausted what was capable, or if he started to decline more functionally at home, needing more help. And that's when we would bring in hospice. And he went several months. He was able to cook his last Thanksgiving dinner for his family. And then ultimately we did end up transitioning to hospice, and he passed, but with his family all around him in a much more peaceful way. So that's my patient story.
love
And I
that.
hope that gives you an example. We have a lot. I could talk on forever about some
Oh
of the
my
other
gosh.
patients. You could
We always
keep
say
me
we're going to
going.
write a book.
We
So-
should write
so
a
keep
book.
an eye out for it.
But I
Not
think
anytime soon though.
this is the example I hope you take away, that this gentleman got more time. Had we not come in when his function was starting to decline, he had probably about 1.5 years that he was under our care, that he actually felt okay and was able to ride his motorcycle, work in the yard as his pain was controlled. And that time with family is huge. Time is something that we really help to give our patients, as long as it's good time. And he got a little more of that. I'm not going yet. Because the next one is questions. Actually, we're good on time. We had 4 more minutes. But I will open it up to you guys for questions, because I know that's a lot of information. And I apologize, you're getting us late in our day after we've been here taking care of patients all day. So the coffee's kicking in. But I'll let Tim cue me what questions are in the queue. And I did add our contact information. There's underscores.
How do we get back to the queue?
Good question.
Oh,
Oh, good. There you go.
thank you. All right, so I've got a whole bunch of questions about advanced care directors. I'm going to hit you with them all at once.
Okay,
That's okay.
go.
Okay, first off, how often should somebody update their advanced directive?
That's a
Let me-
So are you talking about National Healthcare Decisions Day?
yes, go right ahead.
Tell you what, let me ask you the 3 questions.
Okay,
and
go.
then
See
you
if I
can, okay. Number 2, are advanced directives portable from one state to another or from other states to Delaware? And number 3, how and when do palliative care teams or providers like you two get involved? Does the patient request it? Is it something that's part of a larger, process of patient management that social work suggests? Okay, go.
All right, good question. So, advanced directives. If you're young and healthy, you do one, and you're staying young and healthy, like, you can probably make sure your doc has a copy and whoever your medical power of attorney has a copy, and let it sit. Now, if you're starting to have health changes, development of a chronic illness, serious illness, decline in quality of life at any point, that's probably a good time to pull it out, take a look at that document, and make sure it still aligns with what your wishes are. There is actually a National Healthcare Decisions Day. Let's say it's April 15th. It's tax day, because the only thing definite in life is 16th,
Yes.
death and taxes. That's
Yes.
right. So those are the only 2 definites, right?
Yes.
But we do encourage people who are older that have more chronic illnesses.
I love the engagement.
Yes. That have more chronic illnesses should probably look at those things yearly.
Yeah.
Because their health can change quicker. So April 16th is the day that we encourage a lot of the older, more chronically ill people who are more complex to take a look at those documents each year, make sure the right people have copies, their doctors, their family members, etc. Healthcare directives do cross states. Okay, that is a wonderful question, and especially in the tri-state area where we get a lot of New York, New Jersey, Pennsylvania, Maryland people, and even the DMOST, and any post form for those tri-state areas. A lot of people come to Delaware to retire, and they'll say, well, I did my directive when I was in whatever state, but we need to do a new one.
Nope.
And honestly, some doctors still tell them, well, you need to revise that now. It's not true.
No.
We will abide by those documents no matter what state they were completed in.
Correct.
As long as they meet our criteria. So as long as the criteria is state by state, so witnesses, making sure they have 2 valid witnesses on hand, they should be.
So it's wherever
It was filled out.
It was filled out, that criteria. So there are states that only require one witness. So, and now we only require one.
Now
witness.
we only require
So
one witness.
yes, it's wherever the document was completed.
And then
as you can see, we still correct each other, so it's all
we
good.
do, and we've been together a very long time. It's on a daily basis. But when do we get involved? So it's a fabulous question. And I will tell you, I love the story of the lady who said, I have been asking for palliative care from my doctors for months, and they tell me I don't need palliative care. She finally called us herself and self-referred because she had done her homework. She was a new cancer patient. She was having a lot of uncontrolled symptoms. she was like a stage 2, I think.
Mhm.
But she knew the benefits. And so she wanted us. So yes, you can self-refer. But in the hospital, we do need a physician refer. Yeah, a clinician. So it could be like a nurse practitioner, PA, physician. They can consult us in the hospital. We do actually need that order from them to see patients. But family can request it from the physicians or the care team in the hospital.
And in the outpatient setting, it's like any other specialist. So there is a copay involved if you have a copay for your specialist.
And that's if you're coming to a clinic to see us. The home-based ones may be a little bit different based off of each insurance. But yeah, they can be referred by their physician or self-referred. What other questions you got for us?
Okay. Well, so another little grouping. So can a young person be on palliative care? And then also, well, this gets a even more nuanced discussion. How early can a person, in terms of age, get an advance directive that they are self-directing? Is there like 18, 16?
Now there's no age limit. Whenever the person can speak for themselves and make decisions on what they want, that's so. Like I said before, there's an advanced directive for pediatrics, and then there's an advanced directive for adults. So typically pediatrics is if there's some sort of chronic disease going on
or serious illness, so like cancer, things like that. That's life limiting. Let's use that word. It's a life limiting illness. That they can get involved at any time.
Right. Okay, and then switching to the Delaware medical orders for scope of treatment. Since that's a medical order by a clinician, does that also need to be witnessed, or is that just like a doc writing a script?
That's just like a doc writing a script. The conversation needs to be had either with the person who the DMOST is written for, or by their family member. It doesn't have to be them. An advance directive has to be written by the person. I can't write an advance directive for my mom. She would have to write it for herself. A DMOST, I can have the conversation with the clinician and sign it, and the clinician would sign it.
And each state's post form, DMOST form is a little different because, like Maryland, the physician just signs their form like an order. State of Delaware requires in-person signatures, so it has to physically be signed by the clinician as well as by the patient or the family member to be valid.
Yeah.
All righty. And Valerie, try and use the Q&A. We don't do raised hands. I think you can hear me. Anyway, all right, so another two grouped together. First off is, can you be a palliative care volunteer while in high school? And second is, can you volunteer in palliative care at all anyway?
So that is a great question. Right now, we do not have volunteers for us, but I know the hospital has a volunteer program for teenagers, so I can definitely take it back to my outpatient group and see if they would be interested in getting volunteers involved, because there is a lot of stuff that they can do office and clinically, and a lot of times our patients are lovely and encourage students to participate in their goals of care conversation, so you can actually sit in and be a part of that as well, but not yet. More to come.
All right.
So I don't forget.
Make a note.
Make a note.
Read about the volunteer services and outpatient. Yeah, Bay Health, just so you know, does have a student volunteer program. During the summers, it's 16 and above. And Tim, I can share with you that contact information so that if any of these guys want to reach out to see what other volunteer options are available, it's definitely out there.
Right, and actually, Robin, why don't you stop sharing now so we can see the two of you bigger?
Well, we didn't walk through that yesterday. How do I stop sharing?
There you go.
Should we just hit cancel?
Cancel?
You're good.
Is it gone? Fantastic. Fantastic.
Is palliative care the same for children and for people of different cultures as it is for adults?
So when you say people of different cultures, I think that's the beauty of palliative care. When we sit down and we meet with them, like I was sharing about my gentleman that was a butcher, we want to know about your culture. We want to know what's important to them. I think about the guy we had in ICU that was a Native American, and It was important for him to be able to be outdoors.
Mhm.
We take the culture into account and try to pull it into their medical treatment plan. We want to make sure. I had a Vietnamese man who we knew tube feeding wasn't going to help him live
Mhm.
longer, but in his culture, I think it was Vietnamese, they could not cross over to the other side if they were starving.
Mhm.
So whereas we think that's a natural end of life to not give artificial nutrition, culturally and spiritually, he couldn't cross over.
Mhm.
So yes, any person of any culture can have palliative care as long as they're accepting of us. There are cultures who do not want to engage in these conversations, and we are very respectful
Haitian
of that.
Creole is one of those. They don't like the person doesn't want to know what's going on medically.
They will
let my
defer to their
family do
family.
all the decision making. So it really does matter to hear about the person and learn about the person before engaging in conversation.
All righty.
Today's conversation.
All right, so Terry asks a complicated little question. If you want to be an organ donor, but
Uh-huh.
do not want to be kept alive artificially, how does this work? Will the person be kept alive long enough for the donation?
Yeah.
And yeah.
Robin's going to take it because she loves this one.
Yeah, from a critical care standpoint, like there's a lot of complexity with organ donation, but it depends on the situation. So there is brain death where you're already deemed brain dead, which means if we take you off life support, your body's going to shut down and die very quickly because the brain's not sending those signals out. So typically with that type of situation, you do have to be on life support, but it's not a prolonged period of time. Okay. They have to keep those organs perfusing so that they're good when we get those to the other people.
Mm-hmm.
There is donation after cardiac death, which means you're not brain dead. You're very, very sick. We suspect when we take you off of life support, it's going to be fairly quick that someone's going to die. So in that situation, the organ donation team comes into our operating room, go down with the ICU team in the organ donation room, and they withdraw life support down there in the in the OR, and they wait. They have medications for
allow a natural end of
They
life.
allow a natural cardiac death, and once it has been pronounced that the person is dead, then they harvest as quickly as possible and get those organs off.
If it's within a certain time.
If it's within a certain time period. Mm-hmm. There are times that someone doesn't pass. They surprise us. They don't die in the OR like we think they would. Mm-hmm. And in that instance, they come back up to the ICU, and typically we can provide comfort measures for end of life at that point in time. Mm-hmm. So the short answer of that is if you do want to be an organ donor, you likely are going to have some life prolonging life support at some point in time, but it's not going to be a prolonged period of time.
Correct.
Typically it's over a matter of days that process, like 24 to 48 hours, that all of that transpires.
Right.
All righty. Let's see. Oh, here are a couple of fun.
Oh, this is a Terry question.
Well, I'm going to ask not the most difficult one yet. What's the difference between a do not resuscitate and an advance directive?
Oh, that's a good one. So a do not resuscitate is the actual direction of the person that says they do not want to be put on a ventilator and they do not want CPR in the event of cardiac arrest.
As of today.
What does that mean as of today?
Because the advance directive is based off of qualifying conditions. The DNR is like today. If my heart stops, don't get on my chest.
Sometimes there are some advanced directives that are very clear and say, do not resuscitate. Yeah. But a DNR tells the treatment team what to do when your heart stops or when you've gone through every level of oxygen up until intubation.
All righty. Okay, now the question you've been waiting for from Lori. Does the palliative care team also aid in medical aid in dying?
Oh, that's a good one, Lori. All right, so I'll take this one.
Yeah, go ahead.
So the medical aid in dying law was passed in the state of Delaware last year and goes into effect in January of 2026. The way the law is written, it is the patient's either primary care physician or primary physician managing that illness that deems them limited in life for 6 months or less, approximately. Again, nobody knows that perfect end date and time. So palliative is actually not involved at all. It really is the either primary care physician or the specialist that's treating them for that disease process. Now, the way the law is written is that they have to get education on palliative care and hospice. So we will probably be seeing these patients and providing a lot of education. And truly, if they're getting appropriate quality end of life care, they most likely will not need to use their medical aid and dying benefit.
And what Terry means by that is, can we better manage their symptoms? Like, from a palliative care standpoint, if we can make them feel better, do they still really want to proceed with the dying?
Correct.
Physician assisted suicide.
Yeah.
All righty. And let's see. I love this question. What are the pros and cons of y'all's job? That's Delaware.
I love that. Okay, pros and cons. You start with a pro.
I'm gonna say, between doing oncology, doing ICU, this has been the most rewarding specialty that I have been in. Getting to know patients, helping our medical treatment align with them, and seeing the outcomes, and helping them during those hardest days. Like, I have so many patients apologize to me, like, I'm so sorry I'm grumpy. I'm so sorry I yelled at you. And I'm like, I don't meet anybody on a good day. Like, I meet everybody on their worst day. So if you yell at me, it's okay.
It's okay.
But I think just seeing them afterwards, like when they say thank you so much, they hear palliative. We walk in and they're like, oh my God, palliative. I'm dying. And then by the time we're done, they have such a bad understanding. Yeah, no kidding. Or bringing me sweet potato biscuits. But the fact that they're like, thank you for that. Thank you for helping me understand better. Thank you for talking to my family with me. Those thank yous probably are the best part of my job. What are yours?
Okay, I'm going to say a pro. I was going to say a con, but I'll say a pro first.
No, we both need pros and we both need cons.
Okay, so my pro is that I get to sit down and get to know my patients. I get to find out about their families. I get to find out their wishes, their goals, their loves, their hates. We get to really know our patients. And I'm going to read to you something that my colleague wrote yesterday. She goes, today it was so-and-so who had the cleanest gutters in her Florida neighborhood, another one who loved working for 30 plus years in a small deli in Dover, and another one who loved watching Murder, She Wrote. Those were her patients that she took care of yesterday. So, you know, and when I asked Robin to tell us about her gentleman, it's hearing and getting to know the story behind the illness. It's the story behind the person, that it's not about the illness, it's about the person.
So many times, I think in medicine, we look at a patient as a diagnosis. We're looking at numbers. We're looking at a body laying in a bed.
The heart failure in 23 or the diabetic in 12. It's not about that. It's about who that person is.
It's bringing to light the person that's laying in that bed and making sure that the patient feels that we acknowledge them as a person, and that our care team remembers.
Sharing that,
yes. Man, these nurses are so stressed out all the time. And when I can go out and share with them a little bit about that patient, I mean, I can't share that one. That was a doozy.
No.
But there are some really good stories that lighten the load and help these nurses get through the tough day. But it also gives them a different perspective of that patient. They go in there and they talk to them a little bit more. That then makes that patient a little bit better. So I think that is definitely the con.
My con is
you go first.
Going into the room and being perceived like the Grim Reaper before they really know what we do.
Yeah. I think my con is the frustration sometimes with trying to coordinate care between multiple specialties. So that is one of the things that is one of the biggest frustrations with patients. I've got a cardiologist, I've got an oncologist, I've got a kidney doctor. The kidney doctor says no more diuretics. My heart doctor says I need more Lasix. Nobody's talking to each other. Which is a
diuretic.
And they're all getting different orders. And I had one patient say, I've had 5 different doctors in here today, and they've each told me something
like 5
different.
Different things, yeah.
And so,
and that's the challenge of healthcare these days. Everything is very siloed. A cardiologist is focusing on just the heart. A pulmonologist is focusing on just the lungs. an oncologist is focusing on just that cancer diagnosis. But what we don't remember is that all of those systems,
Work
although
together.
independently, work together. And when they're not working, the other ones start to fail. And nobody says that to the patient until we come in.
And so sometimes we are the team that tries to bring the whole team together. That's probably my least favorite because it can be frustrating at times, but it is also on the flip side the most rewarding.
Yeah.
So when we can get that team together, when I can say, look, we need to step aside as a care team and we need to talk about the whole picture here first before we present treatment options to this patient and family again. It makes a world of difference. It's just a lot of work. That's my least favorite part.
Yeah. And we go both ways. You know, people think that we only go in and focus on stopping treatment or decreasing treatment. There's a lot of times where we're going in and the doctors are like, this person's terminal. I think they need hospice. And we're like, no, that's not what their goal is. Their goal is to live another 6 months to get to their
So what
daughter's
else
wedding.
can we do?
What else can we do? And how can we get them there? We need to get them to this date. And if we can, we do. And sometimes we can't, and we are honest with them. So,
But sometimes we can. And that's really nice. I feel like a lot of times in palliative care, I'm actually advocating for patients to meet their goals.
right.
Because even though we know that the inevitable is coming,
Yeah.
we might be able to meet their goal to get them to Christmas, to get them to their granddaughter's graduation, to see their pet. Whatever their goal is to give them more time, that's what we're advocating for our patients and going to work to try to get them to.
Yep.
All righty. So, I had an email in between here. So with Valerie St. Bernard, what's happening is Zoom can recognize gestures that we use.
Oh, shoot.
Apparently that's turned on her computer. It's called raise hand or thumbs up emoji. It's gesture recognition. So thank you, Valerie, for emailing me. I just didn't want you to miss asking a question. Okay. How do you manage so we talked about the pros and the cons. How do you manage your mental health after a long day of working in palliative care?
Actually, each other. I think our sense of humor.
Yeah.
Can you tell? We don't take ourselves very seriously. We have to laugh a lot when we can. We cry together when we have to because there are hard days.
Absolutely. Absolutely.
I run. I like to be outside. A good run, even though my knees hate it. Mentally, it helps. Terry,
I play pickleball.
She plays pickleball.
Despite
the torn meniscus.
Yeah, despite my torn meniscus. But yeah, so spending time with family, getting out in nature is super important. Healthy eating and taking care of our bodies,
That one's hard.
which we sometimes have a hard time with, as evidenced by the candy in the background.
The M&Ms.
But in the same token, that also brings relief to not only ourselves, but also to our residents, to our fellow clinicians who come into the office to find out what exactly we have to share.
What do you got in here we can eat? It's been a rough day. Do you guys have chocolate? Do you have something good?
Yeah. So, and our families are so understanding because they know the kind of work that we do.
Yeah, they really are.
So Lori asks another great question. If a palliative care patient or a patient who's a hospice patient or whatever is in the hospital and will not be coming home, they are going to pass.
Yeah.
Is it possible for them to see their pets one last time so they can say goodbye?
Oh, yes.
Yep.
I actually had one guy who swept. He wouldn't let me clean up the dog fur. We left it in the corner of the room after the dog had been there for a visit because he wanted it to keep close. Housekeeping wasn't happy, but we left the dog fur.
So yes,
and cats are a little squirrely, but
cats are squirrely, but they have come in. We've had people bring them into their cat carriers, and the dogs have to be on leashes, well behaved, but yes, pets are allowed to come in.
Right. How about birds?
We had ponies in the ICU.
Oh my gosh.
A year and a half ago. Now, granted, I think the daughter may have fudged and said they were therapy ponies. But when I walked in and I was like, oh my gosh, they're legit ponies. Like, I didn't know you really meant they were like ponies. I just
thought they were big dogs.
Oh my gosh. So, last question of the day. Do you feel the honesty of palliative care is an unusual reward in medicine today?
Yes,
Yes.
100%. I think that's probably one of the biggest thank you.
Yeah.
Granted, when we have these conversations with people, one of the first questions we ask is, what do you know? But then followed by, what do you want to know? Because like Terry said, there's some cultures that don't want the honesty. But I would say probably 95% of people say, like, look, just tell it to me, Frank. I don't want you to beat around the bush. And people are very appreciative of honest, frank information.
Yeah, they want information. They want to know what's going on so that they can, again, you can't make a decision for yourself unless you know everything that's going on. You have to know all your options, and then, you know, you have to take time to reflect on those options. We also encourage family members to be there as a support. You know, haven't gotten poopy diagnoses. You hear that C word, or you know, the curtains come down and all information stops going in. So having somebody there to get that information for you when you're ready to accept it later on is really important. So it's definitely important to have that engagement with family.
And I think the honesty, palliative is a key component of critical care. It's a key component of oncology care. And that honesty is important in both of those specialties as well. But I think I enjoy being able to help bring that honesty into those areas. And patients and families are typically very appreciative of it. Maybe not right away because their emotions are high. You have to remember, everybody copes with difficult emotions in different ways. So there are people who yell and scream. There are people who pass out. There's people who cry. But those people typically come back later and say, look, thank you very much. You know, we appreciate this. I know, you know, it's not easy. We're very upset, but we do appreciate what you guys are doing. And those are the ones that's our pro. That's why we do what we do.
Right. So I wanted to chime in here and see whether I am up to date on the lay of the land here. So you had a slide in the beginning that talked about hospice being the last 6 months of life, but
Correct.
I think in reality that is that's an initial eligibility, and in some cases that's actually prescribed by I think Medicare eligibility.
It's the Medicare criteria for hospice that they have to have that 6-month or less prognosis.
But the reality is that some people come into the hospice and they live a lot longer than expected. Other people come in and they're barely there for 5 minutes.
Correct.
And they're gone.
Correct.
So vis-a-vis palliative care as being a segue into it, it's part of a continuum. It's not like one day it's this and the next day it's that.
Correct.
And palliative, the principles of palliative care continue even into hospice care, if I'm not mistaken.
Yeah, correct.
So we think about, for instance, with oncology, with cancer, we think about chemotherapy as being therapeutic curative. But and it can also make you feel just terrible, but if that chemotherapy is going to keep you alive long enough to see your first grandchild, your kid get married or whatever, then actually we need to be a little bit more flexible in how we think about that continuum of palliative to hospice care. It has been wonderful to hear from 2 people who share so much experience with my own experience. Christy, I'm sure the same for you. Thank you very much from all of us. And next week, we're going to be learning from Dr. Carl Poblas, who's going to be talking about pharmacy.
Yes.
Great evening, everyone. Thanks so much.
Thank you guys for inviting us.
Yes, it was an honor to be here. Thank you so much.
Okay, bye-bye.
Bye-bye.
Bye.